As we begin today's conversation on the effectiveness of the Office of Integrated Veterans Care, our focus is a simple one: ensuring veterans receive the top-notch care they deserve and have earned, whether in the VA or in the private sector. As the largest integrated healthcare system in the country, VHA provided more than 115 million clinical encounters to more than 6.3 million veterans last year. That included 31 million telehealth appointments, 40 million in-person appointments, 38 million community care appointments. Let me say that one more time. 31 million telehealth appointments, 40 million in-person appointments at VA facilities, and 38 million community care appointments. Are there often problems accessing care, particularly in rural America? Well, the answer to that is yes. When that happens, we hear from constituents, we hear from VSOs, and we often rely upon entities like the VA Office of Inspector General and Government Accountability Office to tell us what's going wrong and how we fix it. Recently, a nationwide Medicare survey of patients showed VA outperformed non-VA hospitals on all 10 core patient satisfaction metrics. Those included overall hospital rating, communication with doctors, communication about medication, and willingness to recommend the hospital to another. Study after study, including findings recently published in the Journal of General Internal Medicine, shows VA healthcare is as good as or superior to what folks get outside the VA. And veterans typically like their VA care more than their non-veteran counterparts like in the private sector. But when veterans can't be seen by the VA in a timely manner, or they have to drive too far for the VA services, they need to be quickly connected with community care. Despite what some believe, the simple act of routing more veterans into community care is not the sole solution. The challenges of accessing care, particularly in rural and frontier America, are not specific to the VA. Communities in a state like Montana know that all too well. And as I said at last week's hearing, improving access to care for rural veterans by purchasing care from the community may have a limited effect, especially in rural areas that are already underserved. You can't buy it if it's not there. So when veterans are sent into the community for care, VA certainly has room for improvement. There's no doubt about that. The department must streamline its internal process for referrals so veterans receive faster access to care. That starts with establishing clear requirements for how long it should take for a veteran's appointment to be scheduled. And the VA also must place special emphasis on hiring non-clinical support staff. VA can't schedule if it doesn't have the medical support assistance it needs to facilitate those appointments. This is not news to any of you. VA and community providers must be able to more easily share information about a veteran's health care so the VA can better coordinate services and make sure nothing is slipping through the crack. Why? Because we can outsource the care, but we can't outsource the responsibility. And to do that, the VA must adopt national interoperability standards for the electronic transfer of health information between the VA and community care providers. The department must also reduce red tape in the community care program. When a patient and a provider jointly determine where the veteran should be best served, that decision needs to be final and not go through any extra layers of scrutiny. Moving forward, I'm open to hearing other recommendations on how to improve community care because the veterans deserve programs that work and that work for them. That's why in the coming weeks, I'll be introducing the Making Community Care Work for Veterans Act of 2023. This is meant to improve the program Congress put into place 5 years ago. That bill will include the provisions that I've discussed this afternoon, among others. In the meantime, we have to keep working to bolster VA's internal capacity to provide care to veterans through the Careers Act and to give the VA the tools it needs to speed up the delivery of VA facilities through the BUILD Act. We've got to address the underlying causes of veterans opting for community care, and we can't do that by focusing on community care alone. With that, I'm going to introduce the panel. And by the way, when the ranking member gets here, Senator Moran, one of you are done speaking, I'll ask if he wants to do his opening statement. You know, it's going to be a little bit flexible here. I want to welcome Undersecretary of Health, the Honorable Sharif El-Nahal. Dr. El Nahal is joined by the number 1 and number 2 from the Office of Integrated Veterans Care, Dr. Miguel Lapus and Hillary Peabody. I want to welcome all of you to the Senate Veterans Affairs Committee. Dr. El Nahal, you have the floor.
Thank you, Chairman Tester. I want to thank Ranking Member Moran as well and members of the committee. Thank you for inviting us here today to discuss how VA is ensuring veterans have access to the best care in a timely manner, as they have earned. I'm accompanied by Dr. Lapuz, Assistant Undersecretary for Health for the Office of Integrated Veteran Care, and Ms. Hillary Peabody, Deputy Assistant Undersecretary for Health for Integrated Veteran Care. We appreciate the opportunity to discuss the efforts IVC is leading to empower facilities to meet the challenges that Secretary McDonough set for this year, to provide more care and more benefits to more veterans than ever before. Meeting the increased demand for veterans in our system and fully implementing the PACT Act requires us to build capacity and improve access to care, whether that be through VA care or in the community. To ensure we are meeting veterans' needs for timely care, VA established measurable goals for all facilities based on feedback from veterans. These goals represent the most important areas we need to focus on system-wide. We refer to these as our North Star metrics, and they include direct care, wait times from the date of request for new patients, time to schedule community care appointments, and veteran satisfaction with the timeliness of care. VA has taken several steps toward improving these metrics. The most important way for us to build capacity is through hiring faster and more competitively. We set a goal of hiring 52,000 new employees this year, including 30,000 positions in the occupations most needed to ensure access to high-quality care: physicians, nurses, practical nurses, nursing assistants, medical support assistants, environmental service technicians, and food service workers. We've made significant progress on hiring, and with our concurrent progress on employee retention, we've already exceeded our goal for the year in increasing the total number of employees on board, and we are still on track to meet our goal for external hires. Additionally, we are leading an effort aimed at optimizing the time our clinicians spend caring for veterans by implementing standards for bookable hours and appointment lengths. The Bookable Hour Initiative will ensure clinicians are available for veteran care for 80% of their designated clinical time. Implementing this represents an opportunity to improve veterans' access to care and will ensure a more equitable workload across providers. Finally, we are leveraging every new modality we have to reach veterans with timely care. We continue to use telehealth, including VA Health Connect, our national network of call centers. Each year, VA Health Connect supports approximately 45 million calls, serving as a virtual front door for veterans into VA. Through VA Health Connect, veterans can call 24/7 to talk to a nurse about a health concern, a medical support assistant to help with scheduling an appointment, a pharmacist to reorder a prescription when needed, and if needed, to meet a provider with a video appointment. So how are we doing? Already we've seen progress in the North Star metrics from Q1 to Q2 of this fiscal year. Wait times for primary care for new patients improved in nearly 60% of our facilities. Further, more than half of our facilities met our first quarter goal for reducing wait times for primary care, and 40% reached the same goal for mental health appointments. Primary care wait times are very important as we continue to implement the PACT Act because these appointments serve as the critical front door and coordinator for VA care. And importantly, we've seen these reductions in wait times even in the context of significant growth in the volume of new patient appointments. We provided 9.2% more of these appointments to veterans in our latest quarter of measurement. We're also making progress on community care scheduling. While the number of appointments scheduled across all of these services in the community also increased, most sites still saw improvements in the time to schedule those appointments. But we do have a lot more work to do there, as you mentioned, Chairman. Candidly, we have seen fewer improvements in specialty care within our direct care system, where salary constraints continue to make it difficult to recruit providers. I want to thank you, Chairman, as well as Senator Bozeman, for introducing the VA Careers Act. This bill would eliminate the $400,000 cap on physician salaries and allow us to provide the market-based pay we need to compete for specialty providers in any market. And here's what we're doing next to further improve performance on the North Star metrics. We currently have 3 efforts underway to improve scheduling: enhancements to our internal scheduling system to allow schedulers better visibility into appointments, piloting of new technology to improve visibility into community provider schedules, and the expansion of veteran self-scheduling.
Oh, that's right.
Veteran self-scheduling has already shown promise in reducing the time to schedule appointments in the community, in our Bedford Medical Center, for example. One veteran in Bedford who was referred to a community dental care appointment explained to us that self-scheduling was the best option for him because he would often miss calls from community providers when he did not recognize the number. By simply providing this veteran with an authorization and the right number to call, VA empowered him to contact the provider on his schedule, which allowed him to secure his appointment in just 2 days. Work is well underway in our Community Care Network Next Generation contracts, where we're incorporating important lessons learned to best ensure that our community providers are providing timely and high-quality care that veterans have earned. Chairman Tester, Ranking Member Moran, thank you again for the opportunity to appear before you today and for your continued support. We look forward to your questions.
I will now turn to Senator Moran for his opening statement.
Mr. Chairman, thank you. The chairman has been kind enough we're working on cooperating with my new committee assignment, which is the Senate Committee on Intelligence that meets every Tuesday and Wednesday afternoons at 2:30. And it has, after we had our schedule already determined what we were going to do here. So I apologize for my tardiness and pleased to be here. I only heard Dr. Ellen Hall about the good news. As you would expect, I have continued concerns about the capabilities and the support for community care. And mostly what I know is what veterans tell me as they experience the opportunities and disappointments that occur both at the VA. We're also mostly here, I suppose, to review and see where the IVC is. It's a new office, combining previously 2 separate offices. The intent in combining those offices into a single entity was to streamline the efforts to improve access to both settings and make it easier for veterans to get the care they need. I don't see the evidence that that's been the case, but I'm happy to hear the testimony that reassures me that it is. A couple of stories that I would tell, just as you were telling yours as I came in the door. A veteran who lives here in the Washington, D.C. area has conveyed to me, to my staff, despite being a long-term patient at a VA medical center here, he decided to request a primary care appointment for the first time in a little over 2 years. He was categorized, he didn't know why, as a new patient of the VA. When he tried to make an appointment a couple of months ago, he was told that it would be 30 days before he could get a primary care appointment. He didn't think that was right. He thought he was entitled to seek the option of community care. But when he asked the scheduler about community care, the scheduler quoted him an access standard information that, when shared with us, it was clearly not the right information, not the right standard. At one point, he was told if he needed to see a VA primary care provider to make a referral to community care. Eventually, the same scheduler told him that, well, if he would call back the next day, she or he could offer him an appointment in just 2 weeks to a different provider. It seems that it's reported that there is a local policy in place that directs schedulers only to look at the availability of certain providers instead of the availability of all providers for possible appointments. Closer to home in Wichita, about a year ago, this veteran started to experience severe pain that was so bad he stopped eating and sleeping and could barely use the facilities. He contacted a VA doctor who advised that he should try Tylenol. Tylenol was not the cure. He went back to the VA and asked over and over again for help with repeated requests that the VA ordered tests and scans and eventually a biopsy. But it took months for those appointments to occur, months in which that veteran continued to have debilitating pain that had nothing to do with being solved by Tylenol. He kept asking the VA to work faster, to get him in sooner, but nothing like that happened. Unlike this first veteran, he didn't know about VA policies, wasn't familiar with the Mission Act. He didn't know that community care was something that he could ask for, little less know that he was entitled to. The VA referred him to the community for certain tests that his VA medical center couldn't perform in-house, but never once offered him the option of seeing if a community care provider could get him the care he needed quicker. A few days before Christmas, this veteran was finally biopsied with finally got the biopsy he'd been waiting for, diagnosed with prostate cancer. At that point, the cancer had spread to several other parts of his body. Fortunately, the veteran is doing okay today. He's in treatment that appears to be working, and his spirits are high. He has good things to say about his VA doctors and thinks that they were just as frustrated as he was about how long it took him during this wait time. He describes the experience, and this sounds so much like veterans that I know. He just describes the VA care as an obstacle course that was extremely difficult to get through. He said that because it took the VA so long to get the care he needed, and he said that cancer got ahead of him. He'll never get the months back and know whether his prognosis would be better if the cancer had been discovered sooner. I understand these are just true stories, but they are stories that I hear, and I would assume others hear on a frequent basis. And so I'm on my continual mission of trying to utilize the Mission Act in a way that it was intended to see that those veterans who need faster care, specialized care, care related to the distance in which they would have to travel is available, and available in a way that there are fewer barriers and less frustrations and less delays. I do know that there are instances, as you were describing, in which the VA in-house performs wonderful services, and most, if many veterans in Kansas, if not most, find the VA care very satisfactory and appropriate. I still am looking for the way to make sure that those who have a better option have no impediments toward getting that care. And I look forward to the conversations that tell me how the IVC is helping accomplish that.
Thank you for your opening statement, Senator Moran. Recently, Medicare did a nationwide survey of patients. VA hospitals, by their survey, outperformed non-VA hospitals on all 10 core patient satisfaction metrics. This is good news for you. Congratulations. The fact that VA is performing well above the average on metrics regarding patient-doctor communication and care transition, really testament to your hard work and more importantly, the hard work of the folks who serve under you, the hardworking employees. So Dr. Elnahal, what do you attribute VA's above average performance on that Medicare survey?
Well, thank you, Chairman, for the question. I think you alluded to this in your question, but the most important reason I believe that veteran satisfaction far exceeds the private sector on average in our system is because of our people. Our people are squarely dedicated to the mission. A third of our employees are veterans themselves. So many more have a veteran in their lives and take the mission personally. And so a lot of the questions on that standard survey issued to every hospital have to do with the respect that we offer patients in our medical institutions. The responsiveness of hospital staff, the cleanliness of the environment, the quietness of the environment. All these are things that our employees pay attention to very closely because they know that every single veteran's experience matters. We are not there where we need to be on every facility. 72% of our facilities are 4 or 5 stars compared to about 48% in the private sector, which is great. But we won't rest until 100% of our facilities are doing that because every veteran, no matter where they live, deserves that superior treatment.
Internal patient satisfaction surveys reaffirm that VA services are top-notch. One metric in particular from this survey stood out to me, 93%. 93% of veterans surveyed stated that they have total trust in their VA facility to take care of their primary health care needs. That is something that can't always be said for the folks receiving care at other facilities in the private sector. So Dr. Elnahal, which metrics from this survey do you look at and say this is a good indicator that the department is meeting the needs of our veterans?
So I think first is the overall hospital rating. It's a summative assessment, what veterans tell us their overall experience was. That's a very important metric to look at. And I think the next most important one is the willingness to recommend the hospital to other veterans. I often say that nobody cares more about veterans than other veterans. And that seal of approval for so many of our facilities really means a lot to us. So those are the two most important, I would say.
So you have a VA integrated care model within the VA, or I should say you have an integrated care model within the VA, not to be repetitive. How does that impact the results from a positive standpoint?
I think that's the entire reason for the change we made to the way we organize ourselves here centrally. The fact is, any veteran may need care in the community. They may need care within our system. And if we take a holistic look at what is best for every single veteran who walks in the door, those processes should be coordinated. Veterans should not have to be ping-ponged back and forth from different departments. The 2 veteran stories that Senator Moran mentioned could be examples of that. I think hearing those stories are not only important, but necessary for us to make the right improvements. And what I can tell you is how this is working at our facilities so far is much better than our system-wide coordination of that integration. We still have some work to do on ensuring consistency of our processes, but I can tell you that excellence is really happening in a lot of our facilities, and we're proud of it.
So that's the positive side of the ledger. Let me tell you about the complaints that I hear. And the complaint that I hear from veterans in Montana, and Senator Moran referred to this, it's the length of time for an appointment to be scheduled. I mean, that's truthfully it. I mean, that's it. I mean, they really can't complain about not having access if access isn't there, but it's the amount of time it takes. So Dr. Elnahal, or either one to your right or your left, walk us through the reasons that there are delays, and what are you doing to fix that?
So I think the most important reason we see delays in scheduling care in the community is that we don't yet have standardized, streamlined processes implemented across the system. That is one of the most important charges I've asked Integrated Veteran Care to focus on to ensure that consistency and oversight. I'll ask Dr. Lapuz to fill in some details there in a second. But I also think that many veterans have told us that they'd rather just schedule the appointment themselves. That's how the care works for care that they get outside of the VA. Veterans feel empowered when you give them an authorization and you give them a community provider within our network. We've seen success on this in Bedford and in areas of Vision 19 as well. And so we want to expand that opportunity to more and more services over time. And I think if we do, the evidence shows that we will reduce the time to schedule. I will also say that that's why this is one of our 3 most important metrics that we are tracking across the system. The time to schedule community care appointments is being tracked in every medical center with expectations for improvement throughout the fiscal year. If we have time, Dr. Lapuz.
Yes, thank you very much, Senator, for that question. So the other thing, too, that we're improving is the technology that is available to schedule veterans in the community. So we have actually, we have a pilot in order to improve the efficiency of scheduling, and that pilot has shown to be beneficial, and that's the reason why now we're in the process of the acquisition in order for us to have the technology so then we can roll out the technology nationwide. And we expect that that's going to be happening probably before the end of the calendar year. The second thing that we're doing is, so we're, as Dr. Elnahal said, that we're improving the processes. Apart from veterans self-scheduling that we are going to be rolling out and making sure that all of the facilities are employing veteran self-scheduling. The other thing, too, that we're doing is we're improving the utilization of what we call Consult Toolbox. This is a process to allow us to get the veteran's preference ahead of time, so then we will be able to schedule the veterans much more smoothly. And then finally, we thank Congress for the assistance that Congress has provided us so then we can hire the necessary staff, because that's the other thing that we're having problems, particularly in the rural communities, that is hiring staff to actually be doing the scheduling. So we truly appreciate the assistance of Congress.
Okay, Senator Moran.
Well, Chairman, thank you. I appreciate what you said about length of time it takes is a significant problem. Recognize that the proposal to have veterans schedule themselves seems like, to me, perhaps a common sense solution, although we've invested a lot of effort at the VA getting schedulers and policies in place. And I appreciate what Dr. Lapuz said about, he added the thing that I was going to add to what the chairman said, as my words, not his, but getting veterans to know they have the opportunity. In fact, they're entitled to have care in the community. And it seems to me there continues to be unwillingness, lack of information, I don't know what it is, a failure, we could say it that way, for the VA to tell veterans, well, here's an option. I don't want to do anything that undercuts the importance of the VA healthcare delivery system in-house, and it's why, but we crafted the Mission Act in a way that was designed to make certain that the VA didn't have a restricted gatekeeping role in providing care to the community. And I have a mission myself of trying to make sure that that is still the opportunity for veterans who make the choice, if it's in their best interest, the criteria are met, that they have that access. So I would add to the chairman's comments about the length of time it takes to get an appointment, that also the confusion or lack of information that comes with both the person scheduling and the veteran who often doesn't know what the rules are. And it is often the case in my experience that when I learned from you, Dr. Eleanor Hall, or anyone else in the VA leadership, this is our policy, it's not what the people in the VISN, in the local hospital know to be the policy. And so you said this earlier, I'm just trying to confirm that what you said is still true. There is not a consistent application of the Mission Act across the country and even across the VISN that I live in. I'd be glad to have any response. Mostly I was just, that was my rant. That's the nature of, that's as bad as it gets.
No, Senator, I think you're correct in saying that we don't see at all times consistent application of these processes. And what is most important in all of this is affording veterans of all options that they're entitled to, including options under the Mission Act for community care. We articulate our priority on access by saying that veterans deserve the soonest and best care option available. Often that is a VA care option. Often it is a community care option, and veterans should be availed of that, as we've discussed before. I do want to give Dr. Lapuz a chance to talk about the oversight work that IVC is doing to make sure we get to a more consistent application of these standards over time. This is a very important effort that the Integrated Veteran Care Office is undertaking. Dr. Lapuz.
Thank you, sir. We are aware, we are cognizant of the OIG findings that there is inconsistent application of policies that are happening in the field, and that there's lack of awareness, like what you have said. And so what we're doing now is we are, first of all, re-educating and training all of the VISNs regarding our policies. So we are also reviewing our policies to ensure that the policies that we have are easily implementable. The second thing that we're doing is we're actually coming up with guidelines and checklists, so then we can share those, so then every policy will have a corresponding guidelines and checklist that we will share from to the facilities and to the VISNs, so then the VISNs can actually do their oversight over the facilities, and we can actually partner with the VISNs to ensure that those oversight visits are being done. So, and then we are monitoring all of the oversight activities that is happening to ensure that, again, there is a consistent application of the policies and guidance that we have put out, so then there is really a singular veteran experience.
I appreciate that answer. Let me tell you about a hearing we had last week in this committee. The topic was substance use disorder. Suicide and substance use are often linked. Overdose deaths have increased, and there's a nationwide fentanyl crisis. I'm not telling you anything you don't know, but I'm telling you about a hearing in which the testimony was the importance of timely connection in the circumstance of substance abuse and suicide prevention, that there can be no delay in the contact between a provider and the veteran. As I understand it, the VA does not hold inpatient or residential substance use services to the same access standards that the VA uses for other mental health and suicide prevention services. Those are minimum coverage insurance policies under the Affordable Care Act have basic access to, the policies have access to inpatient mental health and substance use treatment. Shouldn't that change and the criteria, the standards be the same?
I think it should change, Senator, and in fact, we've charged a group to look into exactly what the policy change should be for our timeliness standards for residential treatment for mental health issues, to include substance use disorder. And that group is going to be coming out with recommendations very soon that we will share when they are ready. But I will tell you that prioritizing access to this critical therapy in light of the epidemiologic trends you were just mentioning around substance use disorder and overdose deaths, we're seeing similar trends, unfortunately, in the veteran population. So timeliness of care for this service is extremely important. We'll be addressing not only our timeliness standards for internal care, but when and how we refer care to the community.
One of the reasons the choice ultimately that became mission was enacted by Congress, signed by presidents into law, was the lack of providers, adequate number of providers within the VA. And this clearly has to be an area in which that is the case, as there are not enough providers anyplace when we get to mental health and substance uses. And so it's, again, it seems to me that it's one of the areas in which the Mission Act has a significant role to play as we try to bring in all the available providers to meet this growing demand. Thank you, Dr. Adelon. You have offered to come to Kansas and spend time with me on numerous occasions, and I look forward to it's in my court, not yours, and I look forward to being able to tell you, yes, I'd love to do that.
Thanks, Senator. Appreciate that.
Senator Tillis?
You looked around the table hoping you could recognize somebody else.
You know, the bipartisan nature of this committee, I was looking for the Democrat.
Thank you all for being here and for the work you do on behalf of veterans. I got a couple of questions. I mentioned in last week's hearing about the Patriot Bill of Rights. I know that we've spoken with veterans, we've spoken with Veterans Affairs since then, but I just want to make sure people understand what I'm trying to do here. My motive is at a time when millions of dollars are being spent to advertise those Camp Lejeune Toxics ads, which the bill was supported by and in large part written by my office. Looks like a great opportunity to get veterans connected that have never been connected to the VA before. So my first question, let's say a veteran who's connected to the VA already sees one of those ads and decides to call 1-800-VA, and they say, I want to file a claim for Camp Lejeune Toxics. What script do they read off to that veteran?
So we have a one-stop shop, essentially, for any veteran interested in getting PACT Act benefits. Mm-hmm. They can call 1-800-MyVA411 or va.gov/PACT. Mm-hmm. We, in fact, screen for toxic exposures to include contaminated water at Camp Lejeune during the affected period. And what happens after that is that it's a warm handoff to VBA after that screening to be able to send that veteran a letter encouraging them to apply for additional benefits. So we encourage that no matter where the veteran is coming from, whether internal.
What about the touch point that they have to make with the Department of Navy as a part of the registration for Camp Lejeune relief?
I believe, Senator, that the PACT Act does offer the opportunity to veterans to essentially sue the federal government for conditions related to the contaminated water at Camp Lejeune.
Well, what I'm trying to get at is the majority of suicides that occur every day are non-connected veterans, not connected to the VA. We always talk about, we had substance abuse discussion last week. Same thing. It's fair to assume that a lot of the people that are succumbing to overdoses and dying are likely not connected. And it just seemed to me to be a perfect time to get two things accomplished. Number one, let these veterans who are not connected know we want them connected to the VA. And also let them know they may not have to spend a dime to get the benefits that they are entitled to if they call a congressional office or if they call a VSO. And so we're trying to put a bill together. We want to get the technical aspects of it right, but we're just simply saying before you sign a retainer for an attorney who is going to take some of the benefits that you would otherwise be eligible for, Have you at least contacted your senators? Have you contacted your congressman? Have you contacted a VSO that's focusing on this? Do they understand all the resources that we want to give them that won't cost them a dime, that could remedy it? For complex situations, go get an attorney. But I'm just trying to figure out, it seems fairly simple. It doesn't cost a whole lot, probably won't make trial lawyers very happy, but it puts us in a position while this subject, and it will be through next year, summer of next year, it's going to be running through the ads. It just looks like a great opportunity to engage more people. I mean, philosophically, do you see any holes in what we're trying to propose here?
Absolutely not, Senator. I completely agree with you that we think the best outcomes for veterans are more possible if a veteran files a claim for their exposure.
I just want them fully informed. It amazes me how people thank me for doing my job in constituent service. And I want them to know that that's what I get paid to do here. And that's one of the primary reasons that I'm here. So we're going to continue to work with you all and hopefully get your support for the bill. I'm not going to have time to go through some other questions, but I do have one on wait times. I've also got, well, I always say I don't do constituent service here. I'm going to break my rule. I know that the Salisbury VA currently doesn't have CAT scan capabilities on premise. Is that a violation of the VHA directive?
They should have CAT scan operations online, and we did look into this issue. The medical center is understaffed in the CT imaging department right now, which is why at certain periods of the week, they do have to refer to a community provider to get that imaging. We really should have that imaging up 24/7. CT scan is a fairly basic imaging modality that should be available at all times for a lot of reasons. And so rest assured, the facility is doing everything it can, especially with the new PACT Act, hiring, retention, and salary authorities to make those CT tech jobs more attractive, and we hope they'll be able to staff up soon.
Well, we're watching that, and you know that particular center is a big catch basin, so I think it's something that we'll be tracking. And Mr. Chair, can I ask one other question?
You bet you
Since
can.
you have no alternative.
Unless Senator Bozeman causes
I
a
forgot.
fuss.
Senator Bozeman, I'll be real quick. On the wait times, I know that we're getting the high-level numbers, but how granular can we get? Can I go to a VISN level? Can I go to a geographic area so that we're all drilling down at the atomic level for me to know where I haven't seen that. I've seen the high-level numbers and the trending, but is that something that you all can just submit back for the record?
We can, Senator. You can also go to accesstocare.va.gov. All of that information is transparently available to the public. Wait times by medical center, wait times by VISN across multiple services, but we're happy to take.
Does it drill down beyond VISN?
Absolutely.
Okay.
Medical
then
centers.
we'll do the homework there. Thank you all.
Senator Tillis, I haven't heard the word granular since we used to meet with Bob McDonald. Senator
I
Bozeman.
miss him.
Thank you, Mr. Chairman, and thank you and Senator Moran for holding this hearing. Taking care of our veterans has always been and still is our highest priority. Access to quality care, especially in rural communities, is essential regardless if they receive the care at a VA or in the community. And we do appreciate your all's hard work in trying to make that happen. Dr. Alnahal, I'm interested in knowing what the average time is for a veteran to receive an appointment once they've been referred to Community Care Referral Coordination Team for scheduling.
So, Senator, where we started this fiscal year was an inexcusably long interval of time. It was an average of about 28 days to be able to get for the veteran to get their confirmed appointment, which is not excusable. And it's also why we have put the time to schedule as one of the three main metrics we're tracking across the system. I want to ask my colleagues if they have the latest average for time to scheduling for the senator. If not, we can take it for the record.
Well, just to be accurate, we'll take that for the record, but I'd like to actually add to the response that, in fact, since we have started looking into this, the average time to schedule community care, what we have seen is an improvement by 60% of the facilities, by over 60% of the facilities. So from first quarter of this fiscal year to the second quarter, over 60% have improved in 3 categories, that is primary care, mental health, as well as in specialty. Specialty, not so much, but in primary care and mental health, we are showing around 60% of the facilities are improving.
No, that's good. And again, I'm not being critical yet, and just really trying to understand. I know how difficult it is to schedule patients, outside of the VA, just within the community to other community members. It's difficult. Do you break it down if you've got somebody that had maybe came in with really significant neurological conditions, somebody that you felt like, was in a situation that really acutely needed care then? Do you break it down how much time it takes to get to that specialist versus just kind of lumping it all together?
Absolutely, Senator. So the referring provider classifies a consult as urgent. We have a standard for that veteran to be seen within 2 days. And thankfully, we are meeting that standard for urgent appointments.
Good, very good. Veterans in rural state like my state of Arkansas face unique challenges to care. I say unique, it's this is something that happens all over the country, but some of these challenges include lack of access to broadband and long driving distances to access quality of care. According to the GAO, about 1/3 of veterans enrolled in the VHA live in rural areas. Additionally, GAO found that 17% of people living in rural areas lack broadband access. Given these challenges that rural veterans face to receiving care, can you speak to what the VA is doing to ensure rural veterans are receiving access to community care?
Absolutely, Senator. First, on your point with broadband, and I'll pass the community care part of the answer to Ms. Peabody in a second. But we have a program with the FCC that actually does allow for support in the form of financial support for veterans to be able to get broadband. And we also do have a program that offers devices to veterans to be able to receive telehealth appointments. And there's been some significant uptake in that program, especially in rural areas. I've also charged our Office of Rural Health to look into other options to potentially offer broadband within our current authority. And we'll come back to you with ideas on that if we don't have the authority to do so. Ms. Peabody?
Thanks for the question. 2 things I'd like to mention, Senator. One is our VA Health Connect, which Dr. Elnahal mentioned in his opening testimony, that's already taking about 45 million calls a year. That really serves as VA's front door. So we want to be able to expand some of those capabilities with VA Health Connect, expanding what we're doing in the several VISNs where it exists today so that a veteran can just call. We're looking at doing tele-emergency care through VA Health Connect as well. So I think that's one way that we should be able to reach more rural veterans. With respect to our community care program, we are currently in the thick of some pretty heavy market research for our community care next gen contract. And so one of the things we're looking at is getting some industry feedback on how we can do that better. What are some unique industry ways we can do that in rural areas? Thank you.
Can I ask one more question, Mr. Chairman? What's your biggest obstacle? You've got, you're in situations where people need to get into the community for various reasons. You don't have the ability to take care of them. What's your biggest hindrance to that? I said earlier, I understand, I was a former provider. I understand how difficult it is referral patterns are anyway. Is it that? Is it lack of access to specialists, or is it, are we not paying enough? Is that a factor where, where perhaps providers are limiting, their access to VA care that way? What's the biggest handicap that you have as far as getting people in the hands of these folks?
So candidly, Senator, I think the biggest bottleneck now is our scheduling process. It takes much too long. It requires our currently in many places understaffed offices of community care throughout the field to go back and forth between community providers and veterans themselves. I mentioned an example in my opening about a veteran out of Bedford who is able to schedule his own appointment in 2 days because at that medical center, they have veteran self-scheduling across all of their community provider appointments. Because the veteran knows their own schedule, give them an authorization, and providers within our network, they can do it themselves, which is another reason, which is the major reason why we are doing self-scheduling across more and more specialties, to include optometry, by the way, your field. And so as we continue to try to increase that option, we hope to see that process get better.
So your schedulers don't seem to have that much flexibility. Is that correct? I mean, is it more rigid than in private practice, or?
I think they're understaffed. That's one of the major issues. The workload is significant. And I also think the systems that they are using are not meeting the needs for an efficient workflow, which is why Dr. Lapuz highlighted earlier our acquisition effort for a community care scheduling system, whereby we can work directly with our community providers, see directly into their grids should they agree, and make that process a lot easier.
Good. That's helpful. Thank you all very much. Thank you, Mr. Chairman.
Just a quick follow-up. I think Senator Blackburn is going to be coming in a second. So we have had many hearings on electronic health records. Does the electronic health record potentially fix this scheduling issue?
It
Or
doesn't.
as a community care component?
It doesn't in and of itself, Senator. So we're actually in the market for a scheduling system that would meet the need for community provider scheduling. We do have the option to use that scheduling module. It's in use in one place in Columbus, VA, and it's part of a number of things that we're going to try to improve across the 5 sites during the reset period for the electronic health record. But that is not the system we've committed to using because, again, a lot of these improvements need to be made.
Okay, Senator Sullivan.
Thank you, Mr. Chairman, and appreciate the witnesses here today. I have a kind of a really important issue, and kind of been here before, but we really need your help on it, and it's with regard to call centers. So when I first got elected in 2015, I think it was the Mission Act, they had removed the local call centers that were based in Alaska, I think down to Louisiana or something. And so we had the VA call centers that were really good and effective in Alaska. And then they were moved. And then you had people in the lower 48 who were making appointments for veterans based in Alaska who had no idea about Alaska. And, it's a very big state. And you'd have, let me give you one example. You have someone from Ketchikan, and they would call, and these guys would say, oh, you can just drive to Anchorage. Well, you can't drive to Anchorage from Ketchikan, right? So it was just basic stuff, and it really, in many ways, collapsed the system. So the new incoming Undersecretary, Dr. Shulkin, who later became Secretary, he came up to Alaska, saw this chaos, and committed to me to fixing it, which he did, brought the call centers back. Well, we're having the same problem again. As you probably know, VISN-level call centers are to ensure a consistent experience for veterans. Alaska is part of VISN 20, which includes Washington, Oregon, and West Idaho, which of course would make it the biggest region by far. And we once again have call centers that have been moved out of the state. And so the number of veterans, so we have nobody who understands the geography, who's just making the basic appointments. And so I'm trying to get you guys to commit to supporting a new VISN call center. This is kind of going back to 2015, that we be based in Alaska to support the consistent experience for veterans, which is what you testified to. And it just makes sense. The number one issue I'm hearing from our veterans right now is this issue. Call centers, they don't understand it. The wait times are long again. But the VA does a great job in my state when they're local, but when they're outsourced to other places, it's not their fault really, but they just don't understand the geography and what it takes. So, you know, we don't have a full-service hospital, the VA, in the whole state of Alaska. We have more vets per capita than any state in the country. I'm just hopeful that you guys can bring back call centers to have better service. So I'd like to get your view on this. I've raised it with the secretary. I think he's amenable, but this would give, again, to your testimony, it would ensure consistent experience for veterans, regardless of where they live.
I'm also amenable, Senator, and I appreciate you making me aware of those concerns from your constituents. This may have been a function of the transition to VA Health Connect, which is the centralized visit-level call centers.
It was.
As you were mentioning. And so I understand that Alaska is a unique environment. I do hope to visit at some point.
Yeah, we'd love to have you
perhaps,
this summer.
Travel, yeah.
Salmon are running, right?
But absolutely something we have to look into because we need to serve vets in Alaska to the best extent we can.
Okay, and again, I appreciate the commitment. My staff and I will work with all of you. It's just deja vu all over again. Got fixed last time by Dr. Shulkin, and we're in the same spot, and we're hearing the same challenges. And so if we can work with all of you on dealing with this issue for community care, especially care, it would be really helpful. So thank you for that approach. I think the secretary is, like I said, amenable, and we all share the same goal, which is getting our vets the care they've earned, and this is an important way to do it in my state. Thank you. Thank you, Mr. Chairman.
Senator Blackburn.
Thank you, Mr. Chairman, and thank you all for coming in. Let me give you an example of some of the problems Tennesseans are having with implementation on community care, which is something they really want. And I had one veteran from Chattanooga recently was giving me her story of trying to get community care for mental health services. And she was telling me how frustrating this was. And she likened it to going to the DMV and having a really bad experience and having to jump through all the hoops that were there. And finally, after meeting everything the VA made her do on community care, 8 months later, 8 months, she was able to see a mental health specialist in Chattanooga. This is so totally unacceptable. And it is as if the VA is trying to stonewall people and not let them into the community care program. Some of these individuals do not have someone that can take a day off work and drive them to a VA facility. And when they call, they're needing help then. Likewise, right now, and we check regularly to see how long the wait times are. If you wanted in Clarksville to go to a primary care physician, let's say you're sick and you call today and say you need to see someone in primary care at the VA, 28 days. In other places in the state, it's 74 days, 100 days to see somebody. So we have got to do something about allowing veterans to get to the care they need at a place where they are able to get the care. And that's the whole purpose of community care. And I've got a Veterans Healthcare Freedom Act that would create a pilot program that removes these requirements that a veteran has to get all this pre-authorization and jump through these referrals. And Dr. Elnahad, do you think that veterans can make these decisions on their own? Do you all trust them to make these decisions? Why are we getting these continual roadblocks? Is it the employees union that doesn't want this to work? What is the issue?
Well, Senator, the first thing I'll say is if the veteran isn't amenable and your office is amenable, we're happy to do everything we can for the veteran you just mentioned. that's an inexcusably long wait time. I agree. And
We have a
to do
long
better.
list of those.
Yeah.
That's just one.
And again, we are happy to review every single one and meet their needs. We have a patient advocacy office that can help us with that. More broadly, it is why the problems you are mentioning are exactly why I have identified the time to schedule veteran appointments in the community as one of the most important metrics we're tracking across the system. And where we are seeing deficiencies and inexcusably long wait times, we're honing in on trying to improve them and standardize those processes. We're also trying to expand the program that allows us to simply hand a veteran an authorization and a list of providers in the community that are in our network and empower that veteran to schedule the appointment themselves. Where we've tried this in certain areas of the country, Bedford, Massachusetts, VISN 19, we've seen success. We've seen that care coordinated
That
sooner.
is what veterans want. Well, let me ask you this. If that's your goal, is to say, here you go, here's a list. If they call the VA, they can email that list back to them right then so they can call through. Then why did the VA take down the Mission Act website?
So I think, Senator, the website has the content that it's always had. The purpose of the update to the website was to offer a one-stop shop to veterans online to understand all of our programming, both internally within the VA and in the community. I am squarely focused, in addition to improving access to our direct care system, on making sure that the veteran experience through our community care program gets better and better. And again, we've identified that time to schedule, the coordination of care in the community as the most important things we have to improve, and you can be assured that I'm very focused on that.
Well, I would encourage you to try one of your pilot projects in Tennessee, because we could give you a list of stories like this, a list of people that are waiting, as I said, 30, 70, 100 days to see a primary care physician, a list of people that are waiting for oncology, and they're waiting months. So we would invite you to try one of these pilot projects in Tennessee. Thank you so much for being here today.
Thanks, Senator.
The good Senator, Dr. Cassidy.
Thank you, Chairman Tester. I'm going to probably ask some questions that are kind of 101, just to try and understand. And I apologize if others have asked. So somebody is referred to a cardiologist. Now, the cardiologist has a whole list of things that the cardiologist could order. Does that authorization to the cardiologist's office include a pre-authorization for whatever test the patient, for whichever test the doctor would order?
I'll ask Ms. Peabody to help with that question, Senator. Thank you.
Senator, yes, that's correct.
Now, so now I'm going to approach this from the other side. There are some providers who are overutilizers. And if you overutilize, you obviously have an increased risk of complications. So if somebody goes with chest pain, you get an EKG, you get an echo, you get a treadmill, you get a radionuclide study, other tests. I'm a little rusty on my healthcare. Could they go all the way to a cardiac catheterization on that same authorization?
Senator, one of the things that Dr. Elnahal has actually charged our office with is taking on looking at appropriateness of care. As we look at our future CCN contracts, we know that we've got to find unique ways to better address making sure our veterans get the right quality of care. So as part of that, we're in the process of developing a strategic plan and roadmap for how we'll be
Can I stop you a second?
that. Yes, sir.
But now, I'm just speaking now, not as in developing a roadmap. If I have that pre-authorization for that doctor's office, could that doctor take me all the way to a cardiac catheterization with no review of whether or not that cardiac catheterization would be appropriate or not?
Dr. Lapuz, do you want to add?
For outpatient, not necessarily. So cardiac catheterization is not authorized for outpatient care. Now, on the other hand, sir, if the veteran went to the emergency room, that cardiac catheterization would be part of the COC for that emergency room visit.
Now, are you doing, because we also want to make sure that the veteran gets the care the veteran needs, but we also want to be protective of taxpayer resources. And we know that I'm a physician, so I'll just say that there is a subset of physicians that will greatly overutilize if there is no check on what they order. So has there been any ongoing evaluation of the people to whom the VA refers or has in their provider network as to the amount of testing they order and by extension the appropriateness of that testing?
So, Senator, I will say that you are highlighting one of the major risks that we see right now. The good news is that in my charge, as Hillary mentioned, to integrated veteran care on doing more work on appropriateness of care, a lot of this data is already public vis-a-vis Medicare. So we have ways of
I'm with you on
looking
that.
into-
So
Yeah.
I know, believe me, I understand, you can understand if somebody is ordering this test, 2 standard deviations more than everybody else.
Yes,
And there's guidelines from, the cardiologist that say, no, you should only be ordering it here.
yes.
Is the VA looking at that and looking at the, okay, this is how much I'm being charged? Are you looking at a frequency distribution to make sure that we're only putting people as providers who are ordering tests appropriately, knowing that they could appeal, there can be a review, there may be some extenuating circumstances, but also knowing that some people will order too many tests?
So, Senator, we do not consistently look at that right now when we do authorizations, and I've identified that as a risk to veterans, most importantly, because overutilization
Now,
is not
now
just
let me
a cost
ask,
issue.
because I think it was a couple of years ago that I asked the same question.
Okay.
And so is there, and I can't blame y'all. I mean, Ms. Peabody is from Tulane, and I will forgive that. I'm an LSU graduate, but no, I'm just teasing. You're an LSU, you're a Louisiana person. I like that. But I guess my point is, having raised this issue before and finding that there isn't a program in place, but like every insurance company in the nation has a program like this.
Yes.
This is not new territory. And in the Mission Act, the VA is effectively an insurance company.
Mm-hmm.
So is there any thought of contracting with a third-party administrator using off-the-shelf tools to allow them to immediately apply a system as opposed to the VA developing their own? I just say that because I don't want 2 years from now to be asking the same questions and finding the same answer.
I think you have the right focus, Senator. I think there are things not only, and I'll ask Ms. Peabody to talk about what we're thinking for the next generation community care contracts with the TPAs, but there are also operational things we can do on just data visibility if we execute it right that will show which providers are high quality, meeting our standards for veteran care, and where appropriateness of care measures are deviating.
Totally with you on that.
Yep.
But I would like to move from the theoretical to the operational.
Me too, Senator. Absolutely.
And can you give us a timeline of when you think you would either contract with a third-party administrator or be able to use this kind of transparency? Because ultimately, I don't care what you do. You're either spending money, but even minor tests can have complications.
Yes.
I mean, I can just tell you. You do procedures, sooner or later you have something going on. So I'm just sensitive to this.
Senator, there is one thing that gets at what you're asking, I think, that we have put in place. We just haven't implemented it universally, and that's our high-performing provider program. So we are using from both of our TPAs, from TriWest and from Optum, they're already, normal insurance industry recognized standards, and they've done some customization for VA. And you can see within PPMS, which is our internal provider directory that the schedulers use to find a provider for our veterans when they're scheduling, they can see if the provider has that HPP designation. What we have not done is mandated that you must schedule to that or that you have to tell the veteran. So we're working on figuring out how we can better optimize that. And then as part of that CCN Next Gen contract, getting to your question about timeline, I think we will most likely put some additional requirements in place under that contract, which will be in place in the next couple of years.
I'm not a cardiologist, but I'll also say, going back to Dr. LaPuz's point, just because someone goes to the ER with chest pain does not mean they should be cath. There's a lot of other reasons for chest pain that can be evaluated before cath. It also seems like that sort of, and every now and then somebody dies from a catheterization. So it does seem as if you could do a frequency distribution there. I'm just asking that and would ask you all to implement it ASAP for the variety of reasons that we've discussed. So thank you.
Senator Cassidy, I want to thank you for that line of questions because I think it's spot on. I mean, if you take a look at the growth in money that we're putting out for community care, it is exponential. It's predicted to be $2 billion a year for the next 3 or 4 years, additional to the 23.5 we're at right now. And I think that point is a point you talked about, spending taxpayers' dollars appropriately. And so I'm willing to work with you. I'm willing to work with you guys to make sure that people are doing the right thing, basically. So thank you. I want to thank you guys for being here today. Appreciate it very much. I look forward to continuing to work with you to ensure veterans receive timely, quality care in the VA and in the community. And we will keep the record open for a week. And as long as there are some questions you've already taken for the record, I would like you to get those answered as soon as possible. With that, this hearing is adjourned.